The need for rehabilitation is increasing globally, and it's even more marked in low to medium income countries where people are aging, they are living longer with chronic diseases like HIV, stroke, and diabetes. These chronic diseases are associated with functioning problems and disability, which make it difficult for people to carry out their activities of daily living. Now, in South Africa, the problem is that the majority of poorer people seek healthcare from public healthcare, but public healthcare is inadequately funded. And so this results in provision of poor and fragmented care. Now, there is this need for rehabilitation to be provided where people are, that is at primary healthcare. But you find that in South Africa, only 3% of the public rehabilitation workforce are actually employed at primary health care. So there is this need to strengthen rehabilitation at primary health care. Now, for that to be done, we need to understand the rehabilitation needs of people at the grassroots level, the end users of primary health care. So this means the patients who are attending primary health care. So what we did is we conducted research in one of the poorer provinces of South Africa, that's the Eastern Cape. And what came out of the research were the challenges, the barriers and facilitators that impacted the access and use of rehabilitation at primary care level. And how we did this is we explored the patient journeys throughout primary health care. So it begins right at home when the patient decides that they need to seek health care, to them actually accessing primary health care, and then also the outcome of their visit to the primary care facilities such as the clinics and community health care centers. Now, if we start at the beginning of when they're still at home, there are already challenges that limit their ability to access health care. Now, if you consider the context of the setting that we studied, for example, in the rural areas, they relied on subsistence farming. Many of them had to rely on disability and social grant from the government, and it could be as little as 350 Rand per month. Now, it would be difficult for them to pay for their transport to get to the clinics, even if healthcare was free at these public health facilities. And most of the patients don't have medical health insurance, so this is coming from their pockets or the money that they're supposed to use for other things. And again, in these settings, we found that the cultural beliefs of the people, most of them believed in seeking help from traditional healers. Not to say that is bad, but it's a more accessible form of care as compared to the medical health facilities. And so you find that people would end up going to traditional healers rather than to the primary healthcare facilities. But few were able to overcome these hurdles and be able to access the primary care facilities. For example, some reported that they actually borrowed money in order to go to the clinics. Now, the question is, are those who get to the clinics guaranteed access to rehabilitation? Well, our study found out that that was not the case. It brought out a lot of challenges that these patients faced. And we categorized these into two major themes. One was the fact that they didn't report their problems related to function when they were consulting with the doctors and nurses. And then the second category was that they were not referred to rehabilitation by the nurses and doctors that they were consulting with. If we go back to the first category, where we were looking at why they didn't report their functioning problems, the first reason was that they had a poor understanding of their own health, their own need for functioning. So it was also affected by the fact that there is no rehabilitation at primary care. So they wouldn't know what rehabilitation is, what it can do for them, and also where to access the services. So they would undermine their own functioning problems. They would view them as normal, part of aging, or as part of the health condition. And there was also the case where if it's episodic, if it doesn't occur frequently, or if it's not severe, then they would also not report those problems. And another reason that they didn't report was their mistrust of the nurses and doctors, their close-knit communities, especially in the rural areas. So they also feared this breach of confidentiality. Yes, and if we look at the second category now regarding them not being referred, we found that they were also passive in their treatment. So they would accept whatever the nurse or doctor said. So there would never be a scenario where the patient suggests rehabilitation. And again, the health system was to blame as well, because the nurses and doctors also hold their perception of the functioning problems. They too also prioritize maybe just dispensing chronic medication and not really finding out what are the needs of the patients or how are they affected at home. So these are the factors that were at the primary care facilities that hindered patients from accessing rehabilitation. Now, if we go to the last part of their patient journeys, that is the outcome of their visit, we have the majority that if they were referred, they couldn't access them at primary care because there is no rehab at the primary care facilities. So again, they're incurring further transport costs and long distances to travel to the district hospital, the referral hospitals. And then we have the few who are able to access rehabilitation at the primary care facilities. But the question is, was it quality rehabilitation? Now, the study brought out that actually there were other challenges that hindered that. So it had to do with language barriers, because you find that most of the rehabilitation professionals don't speak the vernacular language. And then there were things to do with shortage of equipment, assistive technologies like wheelchairs and crutches to give the patients. And so that affects the quality or the outcome of the treatment that is given to the patients. The final part of the study was now looking at the possible solutions for these challenges that were brought out. And we wanted to hear this from the patients themselves. So they wanted to know more about rehabilitation. They wanted to become more aware of what to do for themselves in the absence of not them being able to access rehabilitation at the clinics. And so looking at other studies that have been done, we've seen the importance of having innovations like mobile health technologies to keep patients informed on basic interventions that they can carry for themselves that are simple and they make a difference even without the rehabilitation professionals. And of course, they asked for other things to be done at the system level, like having rehabilitation professionals employed there, but we know that that's not going to happen anytime soon. So it would be important to have interventions in these low resource settings, like upskilling the available nurses and doctors to be more aware of looking out for the rehabilitation needs of the patients and referring them to the to the available rehabilitation services. And they too can learn the basic rehabilitation interventions that they can teach to the patients as well. So that was the gist of the findings of our study, where we said that the patients are not guaranteed of getting rehabilitation just by virtue of having accessed rehabilitation interventions. More needs to be done, and this involves a multifactorial approach, even collaboration with various sectors, because rehabilitation occurs at the health sector level, but the patient will go back to the community. They're going to need to be educated, they're going to need to work, they're going to need to have a home. So there needs to be collaboration with other sectors like housing, social security, education, and so on.